So this presentation is on postpartum tubal ligation, presented to you by Jose Portillo and Brooke Woolard.
So in a quick little overview, we'll start with an introduction, then go over some preoperative considerations, and talk about the anesthetic techniques such as neuraxial with spinal and epidural, local or general. Then we'll talk about some issues with epidural catheter reactivation, and wrap it up with practice guidelines for obstetric anesthesia from the ASA.
In introduction, tubal sterilization is one of the most commonly performed forms of contraception in the United States. It's typically performed on healthy patients that had uncomplicated surgeries or pregnancies. Per ACOG, postpartum tubal ligation is considered an urgent procedure and is performed early in the postpartum period, typically within 8 hours of delivery. Because the uterine fundus is located at the level of the umbilicus, access to the fallopian tubes is facilitated through a small subumbilical incision. Complications such as bowel laceration or vascular injury are lower compared to laparoscopic techniques. A disadvantage of doing the surgery at this time is that multiparous women are at increased risk for uterine atony and postpartum hemorrhage for 8 to 10 hours after delivery. Epidural, spinal, local, and general anesthesia have been used for postpartum tubal ligation, and the procedure is generally short, approximately 30 to 60 minutes in length.
This is just a little summary of the ASA practice guidelines. Timing for this procedure should be individualized. They should have no oral intake of solid food within 6 to 8 hours of surgery. Consider aspiration prophylaxis. The neuraxial techniques are preferred, and longer post-delivery time intervals increase the risk of epidural failure. This procedure should not compromise other aspects of care. So, preoperative considerations. A pre-op exam is very important in this population. Most physiologic changes of pregnancy are still present in the immediate postpartum period. A thorough airway exam is mandatory in all patients. This procedure should be postponed in patients that are hemodynamically unstable, such as after excessive blood loss, have refractory hypertension, moderate to severe preeclampsia, or sepsis. Patients with cardiac disease are at high risk during the immediate postpartum period due to the increased cardiac output immediately after delivery. There is risk for delayed gastric emptying. Although progesterone levels decrease within the first 2 hours postpartum, patients in the immediate postpartum period are still considered high risk for aspiration, especially if they have received systemic or neuraxial opioids. They should be given non-particulate antacids such as Bicitra, and H2 receptor blockers such as ranitidine, and a prokinetic metoclopramide. Because general is always the backup plan, with any anesthetic, patients need to have no oral intake of solid foods within 6 to 8 hours of surgery. Necessary equipment, monitors, emergency medications, O2 supply, and adequate staff must be present.
Anesthetic techniques for postpartum tubal ligation, as mentioned, are typically spinal epidural, can be spinal epidural, local, and general. The literature is insufficient to support one technique over the other. Neuraxial techniques are generally preferred over general due to the ability to avoid airway manipulation in this high-risk population. If using a neuraxial technique, it's required that a T4 sensory level be achieved. Excessive sedation should be avoided with neuraxial technique to minimize the risk of losing airway protective reflexes requiring immediate airway securement. Choice of technique should be individualized based on the patient's anesthetic and OB risk factors, the patient's choice, and the preference of the surgical team.
So, spinal anesthesia. Spinal anesthesia provides the most reliable surgical anesthesia with the fastest onset, making it more cost-effective compared to epidural reactivation attempts. A T4 level is required. The decreased local anesthetic requirements of pregnancy remain for 36 to 48 hours after delivery, so local anesthetic doses that are required are similar to those needed for a C-section. Hyperbaric bupivacaine 0.5 to 0.75% is generally used because there is less motor block. Lidocaine 5% is not used intrathecally due to reports of cauda equina syndrome. Adding a lipid-soluble opioid such as fentanyl, 15 to 25 mics, can increase the depth of the block. Again, PO Bicitra and a 1 liter crystalloid bolus co-load should be administered. Monitor blood pressure every 2 to 3 minutes after administration. And this procedure often requires Trendelenburg position to improve surgical access. So it is recommended to wait 15 minutes after spinal injection to allow for maximal spread before positioning the patient in Trendelenburg.
Parturients typically already have a labor epidural in place that is able to be used for surgical anesthesia for the postpartum tubal ligation. This eliminates the need for an additional anesthetic procedure. Typically 3% 2-chlorprocaine or 2% lidocaine with bicarb and epi may be used to reactivate the catheter due to their fast onset. These local anesthetics typically require 20 to 30 mLs and for reactivation. As the time interval post-delivery increases, the chances of unsuccessful epidural reactivation also increase. According to the literature, failed reactivation led to increased anesthesia provider and OR times, leading to increased patient cost. There's a higher reactivation success rate when surgery is performed within 4 to 8 hours of delivery. It is not advised to keep the catheter in place for longer than 72 hours. If an epidural cannot be reactivated and no dermatomal level block is achieved, it is recommended that the provider institute spinal anesthesia. If there is some residual block present, provider may supplement with IV opioids, ketamine, nitrous, and local anesthetic, or institute general anesthesia.
Because studies of epidural reactivation have produced conflicting results, it is difficult to predict an interval that will guarantee successful reactivation. When large amounts of local anesthetic have been administered epidurally and reactivation fails, spinal anesthesia is an alternative, although the safety of this is uncertain. Reports of high or total spinal anesthesia occurring when spinal anesthetics were administered within 30 minutes of large volumes of epidurally administered local anesthetics or saline have been published. These results can be explained by several possible mechanisms. Extensive blockade may result from a physical effect of the fluid volume in the epidural space. Alternatively, subarachnoid passage of epidurally administered local anesthetics could occur, producing higher levels of spinal anesthesia. In addition, diffusion of epidurally administered local anesthetics to the subarachnoid space may augment subsequent spinal anesthetics. Although the appropriate spinal anesthetic dose is not predictable after unsuccessful attempts at epidural reactivation, reducing the subsequent spinal anesthetic dose or allowing sufficient time for resolution of the epidural blockade can result in satisfactory anesthesia without complications. Because caution should be used when administering spinal anesthesia after recent epidural reactivation, alternatives include 1. Repeating the epidural anesthetic with a short-acting local anesthetic like 3% 2-chlorprocaine. 2. Allowing the block to recede and administering a single injection spinal anesthetic. And 3. Converting to general anesthesia.
So concerns with neuroaxial anesthesia include hypotension related to the sympathectomy. Pruritus is a common complication typically seen with neuroaxial opioids. Nausea and vomiting is typically related to hypotension. Fever is more likely in women with epidurals. Infection is also a complication, as well as inadequate analgesia, in which case general is also always a backup plan. Local anesthetic systemic toxicity, or LAST, is seen with intravascular local anesthetic injection. You can also have other concerns are post-dural puncture headaches, high spinal, and epidural hematoma.
So for general anesthesia, most of the physiologic changes of pregnancy that put these patients at increased risk for complications with general anesthesia are still present in the immediate postpartum period. Increased airway edema, capillary engorgement, and a narrowed glottic opening lead to increased risk of difficult intubation. Progesterone causes relaxation of the lower esophageal sphincter, plus the gravid uterus pushes up on the intra-abdominal esophagus, leading to a higher aspiration risk. Although progesterone levels do decrease 2 hours after delivery, lower esophageal sphincter tone does not return to normal until 1 to 4 weeks postpartum. Additionally, if the patient received any neuroaxial or systemic opioids for labor, gastric emptying is delayed. A decreased FRC combined with elevated O2 consumption and minute ventilation lead to rapid desaturation, leading to hypoxia and acidosis during periods of apnea. Even with 100% oxygenation, pre-oxygenation for 3 to 5 minutes, these patients can only tolerate 2 to 3 minutes of apnea before coming hypoxic. So general is typically reserved for patients that refuse regional anesthesia or when regional becomes inadequate for the procedure. An RSI, rapid sequence induction with cricoid pressure and a cuffed ET tube should be used. Succinylcholine is the preferred muscle relaxant to aid intubation. It may have a prolonged duration by about 3 minutes due to decreased pseudocholinesterase levels. Non-depolarizing agents are also prolonged, so you must carefully monitor these patients with nerve stimulator and reverse any residual block. Maintenance can be achieved with inhaled agents or propofol infusion. With the inhaled agents, at greater than 1 MAC, they inhibit uterine tone and can lead to increased postpartum bleeding. Additionally, a 40% decrease in MAC is present for 12 to 36 hours postpartum.
So this is a study that we had found from the Journal of Clinical Anesthesia that is a retrospective study reviewing anesthetic management for postpartum tubal ligation. In this research article, they utilized 202 procedures, 47 institutions were surveyed, and 26 responses were received. The primary aim of this study was to review anesthetic techniques utilized for postpartum tubal ligation at their institutions over a 2-year period to determine the rate of successful epidural catheter reactivation, characteristics associated with successful reactivation of pre-existing labor epidural catheters, and compare intraoperative times and immediate postoperative outcomes of different anesthetic techniques. The secondary aim of this study was to survey preferred anesthetic management and timing of postpartum tubal ligation at academic centers with obstetric anesthesia fellowship programs to assess practices amongst different institutions.
So this review found that there's an overall 26% failure rate for epidural catheter reactivation. The time from labor epidural insertion to postpartum tubal ligation was a more reliable predictor of failed epidural reactivation than time from delivery to postpartum tubal ligation. Although epidural reactivation failures occurred in all time intervals evaluated, there is a higher incidence of failure if time from insertion exceeds 24 hours. In these cases of failed reactivation, more anesthetic time was required compared to a primary spinal technique. The highest success rate is when reactivation occurs within 2 to 8 hours of placement. This may be due to there being less time for the catheter to migrate and dislodge.
So there remains uncertainty and lack of evidence to support the optimal timing window to ensure successful reactivation. This survey showed significant variability in timing, utilization of in situ epidural catheters, and anesthetic practice for postpartum tubal ligation amongst academic institutions. Due to the wide variety in reported reactivation timelines, many providers simply elect to avoid attempting reactivation and instead remove the catheter and go straight to a spinal anesthetic technique. Although there are different timelines from provider to provider, epidural reactivation is generally not attempted after 24 hours.
So in conclusion of this article, the only significant factor associated with successful reactivation was time from epidural catheter insertion to postpartum tubal ligation. There was no significant difference in rate of reactivation failure based on the length of the catheter inserted into the epidural space. The use of in situ epidural catheters for postpartum tubal ligation may be more problematic than beneficial. Failed reactivation results in significantly longer OR times to obtain adequate surgical anesthesia. Shorter OR times and lower costs are associated with use of a spinal as the primary anesthetic. The exception to this is if the epidural catheter is used within 4 hours of delivery. So overall recommendations, epidural catheter reactivation should be attempted within the first 24 hours post-placement and ideally within 8 hours of epidural catheter placement or delivery.
So to wrap things up, these are the practice guidelines from the ASA Task Force on Obstetric Anesthesia. Before postpartum tubal ligation, the patient should have no oral intake of solid foods within 6 to 8 hours of surgery, depending on the type of food ingested. An example would be high-fat contact food. Consider aspiration prophylaxis. Both the timing of the procedure and the decision to use particular anesthetic technique, example neuraxial versus general, should be individualized based on anesthetic and obstetric risk factors, which include blood loss and patient preference. Consider selecting neuraxial techniques in preference to general anesthesia for most postpartum tubal ligations. Be aware that gastric emptying will be delayed in patients who have received opioids during labor. Also be aware that epidural catheter placement for labor may be more likely to fail with longer post-delivery time intervals. In a postpartum tubal ligation, if a postpartum tubal ligation is to be performed before the patient is discharged from the hospital, do not attempt the procedure at a time when it might compromise other aspects of patient care on the labor and delivery unit.
And then these are all of our references, and that's it.
Thank you very much.